what I'm going to talk about in the next 40 minutes is really some advances that have been made in understanding the underlying molecular landscapes of advanced prostate cancer, mostly castration-resistant prostate cancer, in hopes of guiding therapeutics of existing drugs and agents, but also hopefully emphasizing areas for new drug development with some recurrent aberrations. These are companies I've consulted for, but I won't really be talking about anything related to specific products from these companies during the talk. So in order to understand how to best deploy therapeutics in advanced disease, it's important to understand the landscape of really those molecular features that underlie the biology of how you may use particular drugs in particular patients. So the first aspect is really understanding the biology of advanced prostate cancer. What are the scope of these molecular changes that we're seeing? What are the causal roles underlying them? What are the mechanisms that lead to their development? Is any particular aberration very common, recurrent across the population of patients that we see, or are they actually quite rare? And then finally, which therapeutics might be most appropriate for a particular molecular aberration? So this really all gets back into, I think, the essence of pathology, which is diagnostics and categorization. And it really goes back to Linnaeus's works in taxonomy of how for all life species you organize these into very specific categories to understand their characteristics. So for cancer, you can really do the same thing. Why do we do this? Hopefully to predict behavior of that cancer and also to identify particular vulnerabilities. So molecular classification understands or underlines a basic understanding of cancer pathogenesis, really drives drug development, and then also drives selection of therapeutic strategies with the whole concept of precision oncology. There's also a technical side of this concept, which is the assay itself. And I would argue that precision oncology requires precision diagnostics. And we're recognizing more and more that these diagnostic results might vary depending on the laboratory you send them to or how the test is actually done, as Howard alluded to. So it's important to understand the reproducibility or the accuracy of the test that you're doing. And then in terms of a patient, what are you actually sampling? And this is going to be very important, I think, in the future. In other words, in a man with metastatic prostate cancer, if you go back and look at his primary tumor and you assess that in a molecular fashion, whether it's full genome sequencing or RNA-seq, et cetera, does that really tell you what's happened in the metastatic tumor? And in a man with metastatic disease, if you sample a single metastases, is that really giving you a reflection of all the different tumors that might be existing in that particular patient? I'm going to touch on that aspect a little bit later on in the talk. So it's pretty clear that cancer behaves in a evolutionary Darwinian fashion to some extent. This has been likened to a tree at some level where you have a root, that initiating cell, and then that divides over time, and you have a trunk, and then it starts to branch out into large branches and then stems and leaves. So for prostate cancer, I'm not going to get into the discussion of what the cell of origin of prostate cancer is. A lot of debate still of luminal cell, a basal cell, whatever the stem cell is. But it's pretty clear we have two big branch points. There are AR negative, androgen receptor negative tumors, and those that are AR positive. And I'll get into this in a little bit later in the talk, but it's pretty clear there are other molecular subtypes that may be very important in determining therapy. So the argument here would be that interpatient heterogeneity is an absolute requirement for precision medicine. That is, tumors from patient number 1, patient 2, patient 3 need to have different characteristics. Otherwise, you would use the same therapy on every patient. However, intra-patient heterogeneity would really curtail the effectiveness of precision oncology or precision medicine. If you had 5 different tumors in this patient and each one had a different molecular driver, then targeting one particular pathway would be ineffective or not very effective for very long. So this would be incompatible with success. So the underlying starting point really for what I'm going to tell you about began with the Stand Up to Cancer PCF, or I should say PCF, Stand Up to Cancer, AACR Dream Team that Howard alluded to. And this study really described the first 150 patients on this clinical trial of obtaining metastatic biopsies and doing deep molecular profiling of these tumors to understand the basic landscape. It's extended now to nearly 500 patients that include patients prior to certain therapies and post certain therapies, and those results will be coming out in the fairly near future. The vast majority of the patients that were evaluated in this study were adenocarcinomas. A very small number were neuroendocrine or small cell cancers, and then a even smaller number which were cancers that I'm calling double negative cancers, and I'll get into that in a moment, but they're basically AR null, androgen receptor null, and do not have neuroendocrine features as well. But the vast majority of these were more classical prostate adenocarcinoma. Now, this slide isn't meant to be looked at with a fine-tooth comb. You can get the impression from a 50,000-foot view. Basically, what the slide is showing is individual patients in columns. So there's 150 patients here, and then the rows are individual genes. And then if there's a colored space, that's some molecular aberration. And so what you should be able to see from the back is that there's a very wide spectrum of aberrations occurring across these various patients. So there's tremendous inter-patient heterogeneity. There's a few things right at the very top is the androgen receptor that are have recurrent aberrations across many patients. And I'm going to have a bit of a dive into a couple of the key points from this particular study and show how it's expanded to consider therapeutics. So the most common aberration, which really surprised no one, was that the androgen receptor was altered in more than 60% of men with advanced prostate cancer that had resisted castration therapy. Primarily, this was androgen receptor amplification. There were a subset of point mutations, and all of these point mutations were activating mutations promoting resistance to anti-androgens. There were a number of other mutations related to the androgen receptor pathway, but again, the vast majority were in the androgen receptor itself. So it comes back to this, I think, key point that we still deal with every day, is that initially you have an androgen-dependent or an androgen-sensitive tumor. With androgen ablation, you eliminate a large number of tumor cells, but there's either at the get-go a small number of resistant cells within the tumor mass, or there's an adaptive process that's occurring in a large number of cells simultaneously. I think there's evidence for both of these occurring, but the end point is at castration resistance, essentially every AR regulated gene is reactivated at that particular point, which really is described as a persistent or an insistent signaling, which suggests that the AR still has a critical, indispensable function. And I can say that the exact same thing generally happens post-abiraterone, post-enzalutamide, post our best therapies that target the androgen receptor. So we went back and looked in a rapid autopsy program at the University of Washington to see if we could see the same events occurring right truly at the end of life, when all therapeutic options were exhausted. And basically we saw the same thing. This is a heat map of the androgen receptor activity, the androgen receptor itself, and then a series of androgen receptor regulated genes. And in the vast majority of cases, more than 90% of these tumors, they still had androgen receptor active in multiple tumors, as I'll show you in a moment from these patients. And many of these had enzalutamide and abiraterone, or the combination of both. So the practical information is the AR is active and still likely a driver or a target in the majority of castration-resistant prostate cancers, even after enzalutamide and abiraterone. We'll come back to therapeutics in the next part. So the second take-home message from this landscape study, which did surprise us, was that there were clear point mutations and copy number losses in genes regulating DNA repair in about 20% of these tumors. The vast majority of these were somatic events, and the vast majority were involved in homologous recombination repair, but there were others involved in mismatch repair, and I'm going to come back to this in a moment. So this is an important take-home, that these occur in about 20% and would have been evident once you obtain a tumor biopsy. The other surprising thing is that germline aberrations were common. In this first analysis, they occurred in about 8%, which really surprised us. These were unselected patients based on any family history of any type of cancer, really. The entry criteria for the trial was simply they had metastatic castration-resistant prostate cancer. So we immediately sought to validate or verify this result, and we all went back to our collective sites and sequenced additional patients with metastatic prostate cancer, again, unselected, close to 700 men then that we sequenced, and we found that the number was actually a little bit higher. It turned out to be nearly 12% of these individuals had a DNA repair gene mutation. The vast majority were BRCA2, but the smattering of others. Now, we cannot say that all of these genes do confer a predisposition to prostate cancer. It's pretty clear that BRCA2 does. There's a confirmatory report of ATM and BRCA1 and PALB2, but the others still remain question marks because they're quite rare, and it's hard to say statistically that they are causal for the development of prostate cancer. Interestingly, in the study, we did not see a higher rate of prostate cancer in the families of these men compared to those individuals in the families of men that did not have a mutation, hereditary mutation. It was very common in both, but we did see higher rates of breast cancer, ovarian cancer, and other cancers that are known to be related to homologous recombination repair deficiency. This is an example of a pedigree. It's not that compelling. You wouldn't immediately look at this family, this is the index patient that was part of the study, and say that this is a high-risk family. So the point being that family history alone is certainly not good enough to indicate who or who will not carry a mutation in a DNA repair gene. So we've made the argument, at least in our site, that all men with metastatic prostate cancer should be offered germline testing and have that discussion with them, with all the implications that associate with that. There are clear reasons to do this. Obviously, family members would have a 50-50 chance, brothers, sisters, fathers, sons, daughters, etc. So here's the take-home. These occurred in about 10% of men with advanced prostate cancer. So I alluded to this hypermutation subtype. So there's a mismatch repair frequency of inherited mutations in mismatch repair genes. This is the Lynch syndrome, but there are also about 5% of the patients that had a somatic aberration in one or more mismatch repair genes. And we'd reported this actually a couple of years ago using model systems. These tumors are hypermutated. They have about 10 times as many point mutations than a typical prostate cancer, which generally has a fairly low mutation burden. These are actually very complex to find, so this is a complex slide. I apologize for it. The take-home is that this tumor actually had 4 independent events that inactivated MSH2 and MSH6. There was a gene translocation in MSH2, a copy loss of the other allele. There was a frame shift mutation in MSH6 and a copy loss of its other allele. So these were both biallelically inactivated, leading to that hypermutation subtype. And this would not be picked up on standard exome sequencing. It's much more difficult to find these kind of rearrangements. And then, so here's the hypermutation subtype that leads to microsatellite instability, and hypermutation occurred in about 5%. The actual number across the population is probably a bit lower than that, maybe closer to 2 or 3%. And then finally, just a brief discussion that there were many other aberrations that were much rarer other than PTEN loss. So there were alterations in AKT, NP10, PI3 kinase, MEK, BRAF, et cetera. And all of these, with the possible exception at this point yet of PTEN, have drugs that can be used to target them. If we do turn out to have effective AKT inhibitors, then this PTEN pathway will be very important in terms of distinguishing it for possible therapeutics. So the other targetable molecular aberrations, 5 to 50% of the whole group. Okay, so that will lead into therapeutics, and I'm going to touch on that in a moment. But I want to come back to the technical aspect or the practical aspect of this idea of what tumor you're actually sampling and how well does it reflect what's happening in the patient. There is a lot of concern and valid concern around tumor heterogeneity and how that may impact how you either choose a therapy or how rapidly resistance occurs or how you may monitor over time. That's all quite important, and it's pretty clear that if there is substantial intra-patient or intratumoral heterogeneity, that would curtail how you would actually deploy and use the concepts around precision medicine. So this study really was an eye-opener for many of us, I would say, in the field. It was a very nice study of doing whole genome sequencing on multiple prostate cancers from men that went to a rapid autopsy. I'm just showing you a blow-up of 10 different tumors from one of these patients. They looked at 10 patients and multiple tumors from each of those patients. So just a couple comments about this. This was by Gundem and Steve Bova and others. So this is kind of the reverse of that tree diagram that I showed you earlier. So here's the trunk, if you will, or in this case, a big root. And then the individual tumors are shown here with their relatedness based on mutations and copy number indicated by the length of those little colored branches. So in this particular tumor, or this particular patient, I think there were 10 different tumors that were evaluated. Most of the action here is occurring in the trunk, meaning that every one of the tumors sampled in this particular patient had all of these aberrations. But there were a couple others that they pointed out. One of this little branch had an amplification of MYC, and there were 3 tumors here that had an AR point mutation. This patient had been treated with an anti-androgen drug. I think it was probably bicalutamide. And then here's the same tumors, but showing the truncal aberrations, and then some aberrations, either mutations or copy number changes, that were fairly exclusive to one tumor versus the other. So out here in the leaves, you can see some unique or tumor-specific aberrations. And the question that we had is, are these important in terms of either deciding on therapy or considering resistance? So we went back to the rapid autopsy program that I described for you earlier. We looked at 63 patients, multiple tumors from these patients, and did whole exome sequencing, copy number assessments, and then looked at transcripts by microarray and RNA-seq. So coming back to the androgen receptor, which is obviously quite important, you might imagine that a given tumor or a given patient, when treated with an anti-androgen, even enzalutamide, and saw resistance, that maybe you would have divergent mechanisms of resistance. Here across these rapid autopsy patients, again, as I mentioned, the vast majority of the tumors still express the androgen receptor and have AR activity. If we break it down by individual tumor, so again, we looked at multiple tumors. Each patient is shown vertically in a column, and then the multiple tumors from that patient are color-coded. And here we're looking at AR expression. And you can see that there's pretty remarkable intra-patient concordance across multiple tumors within that particular patient. Here's androgen receptor activity, so the readout of what the AR is doing, and the vast majority of the tumors within a given patient have the same level of AR activity. Out here are a couple of the neuroendocrine small cell patients with very low AR activity in general. So really quite consistent. If we go and look a little bit deeper, here's 3 different patients, multiple tumors, again in each column from each of these 3 patients. We can see that the overall androgen receptor and AR target genes were highly concordant across multiple different tumors from these patients. Or here's 2 neuroendocrine small cell patients where they completely lacked AR activity but upregulated classic neuroendocrine genes like chromogranin and synaptophysin. These first 2 tumors with the hash line in them are the primary tumors from these patients. So if we went back and collected the primary, this primary would not be a good reflection of what's happening in the metastases. So it's a caveat to using a primary to assume surrogacy for sampling a metastasis. So here's another patient with 5 different tumors from liver and 4 different lymph nodes, and we're looking at AR activity, TMPRSS2 ERG rearrangement, the number of nucleotide variants or point mutations, p53 mutation, MYC amplification, PTEN loss. They were basically identical. And if you superimpose copy number, loss, and gain across the genome, they were also essentially superimposable across here. So if we go back to how that Gundam et al. Paper described the patients from the shared aberrations into the private, so these would be the trunk, the branch, and the leaves out here. The action is still in the trunk. So the known kind of usual oncogene players of p53, I think is located right about here, were all trunkal. If we look out here into the more private mutations that occurred only in an individual tumor, and we go back and look at the Stand Up to Cancer PCF data or the TCGA data, and see were any of these recurrent? Did they happen in any other tumors? The answer was no. These are very rare. So our argument here is that the vast majority of these private mutations are simply passenger mutations. They're not oncogenic. They're not causal mutations, at least at this point in time, following standard chemotherapy with docetaxel, ADT with Lupron or castration therapy, and enzalutamide and abiraterone. Now, other drugs, as clearly has been shown, as Howard mentioned, and I think someone else, that PARP inhibitors can cause revertant mutations. So we're not saying that this will always occur, that sampling an individual tumor will give you the readout of resistance mechanisms, but at least at this point in time when we were thinking about what would you treat next, the private mutations in this case were not going to be relevant. Here we've depicted tumors from the rapid autopsy program based on copy number, gene expression, and then non-synonymous mutations. These ones in red are all from the same patient, so you can see in this 3-dimensional space they all cluster very close together away from tumors from all of the other patients in the study. So the argument here is that if you biopsy this lymph node, it would give you a reasonable representation of the molecular events, the molecular features underlying all of the other tumors in that patient. So it's a reasonable surrogate in the context of metastatic disease. So what we concluded is that metastases share the vast majority of alterations with the other metastases in that patient, though there are occasional outliers, so that sampling one will provide a reasonable estimate and help guide therapy. So there is hope in this case for precision oncology. The caveat here is that primary tumors are well described now to exhibit substantial heterogeneity. They're multifocal, often have different origins simultaneously within the prostate, so I'm not trying to be too cavalier about arguing that all of the tumors within a patient are identical. But what is quite interesting is that there seems to be this convergence where the metastases are quite similar, arguing that the metastases all originated from a single localized tumor in general. So the limited heterogeneity across metastases versus the heterogeneity with a primary, well, how do we really explain this? And I think there's 4 probably factors that intersect to explain this. The first is time. So it's pretty clear that prostate cancers, when they originate probably from a single or cell, that for that tumor to grow to the point of being detected probably takes a long time, 10 years it's estimated. Bert Vogelstein did the similar calculation for pancreatic cancer and made the argument that these incipient lesions were there for many, many years before they were detected. And so at the point for then detection or possible detection, or these tumors having the potential to metastasize, also takes time. But then once you have the potential to metastasize, this one, for example, that's a fairly short time interval, And so these tumor cells leave and metastasize to different sites where you may have intermetastatic seeding as well. So time is critical. The second is that there's clearly a bottleneck in the metastatic process. It's a very inefficient process. So although within a primary prostate you may have multiple foci, at a particular point in time, maybe only one of these has the capability to fully complete the metastatic cascade. There's clearly bottlenecks imposed by treatment pressures. So in our rapid autopsy studies, we looked at really patients that had been exposed to many types of therapy, and as possible, we eliminated certain clones. What would be very interesting is to do these types of multiple biopsy studies on treatment-naive metastatic cases. And then the Gundam et al. Study of the rapid autopsy showed very nicely that you can have intermixing of metastases. And that would also, although you may get heterogeneity within a tumor, it tells you that sampling a single tumor might be also sampling these clones that came from other tumors and then seeded that particular tumor. So many reasons for how this process could occur. So let's get back to heterogeneity in therapy. So I mentioned that this branch point, we now clearly clinically have tumors that are AR null, that don't express androgen receptor, that don't produce PSA. A subset of these are neuroendocrine or small cell, and then another subset are what we're classifying as double negative, but there's many other names for these at this point. And then there's those that are AR positive. I talked a bit about the different breakdown of frequency of aberrations within these branches that include homologous recombination defects at about 20%, mismatch repair 5%, P10, and others, et cetera. So how might we think then about therapeutics and how this can help guide us? So Howard mentioned earlier that it's now well recognized that having a homologous recombination deficiency in a tumor, such as a BRCA1 or BRCA2 loss, confers susceptibility to PARP inhibition. That's been shown in breast cancer, ovarian cancer, approved now in both diseases. Johann de Bono's 2-PARP trial showed the potential of this to also impact prostate cancer, and now there are prospective trials that are biomarker driven where you need to have some HR defect to enter the trial, and we'll hopefully read this out in the not too distant future of showing that PARP inhibitors may be effective in prostate cancer as well with these defects. However, as Howard also mentioned, platinum therapy is approved and we can use it today, although it's not commonly used in advanced prostate cancer. Howard showed this from Heather Cheng and Bruce Montgomery in our group. Here are 3 different patients. This was a case report basically that was published recently. All 3 patients had been treated with standard of care drugs for advanced prostate cancer, and this first one here received docetaxel, abiraterone, and enzalutamide. You can see the PSA trajectory just went straight up, received several cycles of carboplatin and docetaxel. After docetaxel had failed, dramatic PSA decline that remained durable for quite a number of months, even off therapy. And then once PSA started rising, received another several cycles of carboplatin, again with a dramatic response. And we've seen this now cycling out multiple times. All 3 of these patients had BRCA2 biallelic loss, and these associated highly with the outcomes of response in these patients. So we can use carboplatin today, and this is now our standard of care, really. We have 2 clinical trials trying to formally test this because carboplatin, if you read the label, is not specifically approved by the FDA for treatment of advanced prostate cancer. But I would say it's clearly effective in these individuals. I think Chuck mentioned this, and I got the question wrong because I had totally forgotten about it. But yes, PD-L1 blockade is now approved for any tumor with mismatch repair deficiency. And as I mentioned, prostate cancers have roughly about a 3 to 5% frequency of having MSH2 and MSH6 loss with hypermutated tumors. So this will be a consideration for treatment of men with these mismatch repair deficiencies. This was the slide from the OHSU group. You probably can't see that too well, but this particular patient had a dramatic resist response to adding anti-PD-1 one therapy based on imaging CT studies. So there is this subtype of neuroendocrine or small cell cancer. Platinum does provide some temporizing relief here, just as it does in small cell lung cancer. There's a lot of work in this area. It's still a fairly rare tumor, but there's evidence possibly that EZH2 inhibitors, there's an antibody drug conjugate targeting DLL3, and there's several others in the pipeline. But as of today, this is platinum chemotherapy is the primary recommended therapy. AR antagonism has no real effect in this group, at least in my clinical practice. So there's the subtype, the largest subtype, that is still androgen receptor driven, and the question is, how do we address this? It's been challenging. There are a number of drugs that have been starting through the clinical pipeline that target the N-terminus of the androgen receptor because of this idea of the splice variant receptor that's no longer driven by ligand binding, and the AR antagonist will not be effective toward it. There's a fascinating body of literature showing that very high doses of testosterone can actually repress the growth of prostate cancer. Some small clinical trials started to explore this, but probably they weren't done in the proper way of really achieving supraphysiologic testosterone levels. And then I'm going to come back to this in a moment. And then there's clear evidence now through both the docetaxel ADT studies and the abiraterone ADT studies that combinations of therapies are probably going to be the way to go if we can continue to design the right studies. This was the recent New England Journal paper of showing prolonged survival by upfront combination drugs, abiraterone plus some form of androgen deprivation. And I'm pretty convinced that the future really lies in combinations, because our approach of simply sequential therapies still has not really cured patients with advanced disease. So coming back to this idea of supraphysiologic testosterone, this was a very nice, though small study conducted by the group at Johns Hopkins, where men with castration-resistant prostate cancer were treated with monthly injections of testosterone to achieve supraphysiologic levels. So you could call this pharmacologic testosterone. These levels were up in the probably 3 to 4 times a physiologic range. It's really led by Mike Schweizer and Sam Denmead and John Isaacs. And you can see the kind of waterfall plots of response rates. This is by PSA, but you can also clearly see responses on imaging. So about half the patients are responding to reinstitution of supraphysiologic testosterone. And this is well described in the literature. If you go back many years of looking at in vitro models and in vivo preclinical models, you can see that here we have a standard prostate cancer cell line happily growing here. If you add high doses of R1881 with synthetic androgen or dihydrotestosterone, growth repression is dramatic. And in our hands, if you have a castration-resistant line, adding supraphysiologic testosterone is basically equivalent to adding enzalutamide. I won't get into all the details, but some of the patients that were treated with supraphysiologic testosterone and then finally progressed responded to retargeting the androgen receptor. It's not easy to do. Here's a couple PSA plots of patients that were treated with supraphysiologic testosterone. So in this case, the PSA went up pretty dramatically, but the patient was asymptomatic, and then the PSA declined. So you can see multiple different ways of PSA kinetics occurring following therapy. And so it's a cautionary note. I wouldn't recommend simply going out and treating patients with this. There are a number of ongoing clinical trials, including a large one supported by the DoD that should be reading out in the next year or so. I mentioned this, this subtype of androgen receptor null, neuroendocrine null prostate cancer that we're calling double negative. This is from the rapid autopsy program again. Here would be classic AR expressing, PSA expressing, synaptophysin chromogranin negative tumor. Here's a classic small cell cancer with synaptophysin and chromogranin, and then 2 different patients where all of those markers are negative. And so the question is, what's driving these types of cancers? I'm not going to show the data, but there is evidence now through our studies of advanced prostate cancer that this subtype is clearly increasing really over the last decade since enzalutamide and abiraterone were used more widely in the clinic. So here's some data of molecular profiling of these tumors, the double negatives versus the conventional. And what we found, and we think is a driver of at least a subset of these, is the fibroblast growth factor pathway. We see marked up regulation of FGF8 and FGF9 ligands, so it's an autocrine type loop or mechanism. And here's some preclinical xenograft, patient-derived xenograft studies. Here's a neuroendocrine cancer that's FGFR negative and a double negative cancer that's FGFR positive. And with this FGFR antagonist, you see marked suppression of the FGFR positive cancer. So we're hopeful that we can convince a company to conduct a trial specifically in this subtype. So I'll really end here and just summarize that the androgen receptor still remains the dominant driver of most castration-resistant prostate cancer until proven otherwise. So the goal should continue to be to somehow inhibit androgen receptor signaling, potentially overdrive the androgen receptor with this supraphysiologic testosterone, and clearly be thinking about earlier combinations of drugs that can more effectively impair signaling so we don't get the predictable emergence of resistance. I talked about the hypermutation or MSI positive mismatch repair tumor, and there are now approved drugs for that subtype, PD-1 and PD-L1. The assays are very straightforward. Every pathology lab has them because they use them for studies of colon cancer. The DNA repair defects involving homologous recombination are also common, probably a bit more than 20% occurring within the tumor itself. We've got PARP inhibitor therapy coming down the line in clinical trials. Platinum's approved now, and there are possibly other ways to target this pathway, such as CDK12. I didn't have a chance to get into that. And then germline frequency of about 10%. So this is clearly important, and once you identify patients with these mutations, of understanding the genetic counseling that's required, and then thinking about their family members and how best to screen them for early detection of breast, ovarian, prostate, and pancreatic cancer. And then this AR null subtype that we think is occurring more frequently now with the potent AR targeting agents as they develop resistance over many years. And this may be one pathway to target through the fibroblast growth factor system. But there are clearly many recurrent aberrations for which we don't have therapeutics yet, so plenty of work still to do. So many acknowledgments. The PCF clearly for supporting a lot of the work, not only the DREAM team, but many of our studies of DNA repair and androgen receptor function. And then a lot of collaborators, Ellie Van Allen, Dan Robinson as part of the DREAM team, and other members of our rapid autopsy program at the University of Washington. So I'll stop there and be happy to answer questions. Thanks.